Excellencies, distinguished guests, ladies and gentlemen. Next, we are honored to introduce our first keynote speaker, Dr. Saiful Azli bin Muhammad Zainuddin. He is a consultant urologist and the current head of urology unit at the Department of Urology of Hospital Serdang. He completed his medical training at University Science Malaysia USM. He has been involved in organizing many of national level conference, and currently he is the organizing chairman of the 5th International Society of Reconstructive Urology Conference. Without further ado, I would like to invite Dr. Saiful Azli bin Muhammad Zainuddin to give speech about various ways of adult circumcision. Please welcome Doctor.
Thank you, Mr. Chairman. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and very good afternoon. First of all, I would like to express my very thankful to organizing committee, especially Dr. Serdang for inviting me for this very distinguished talk regarding circumcisions. So my topic of today will be the various way of adult circumcisions. So okay, we'll be talking about neonatal or childhood circumcision, but nowadays we'll be talking about adult circumcision. It's not very uncommon, but when the patient come to us, quite a number of patients, adult circumcision come to us, and actually it's not really uncommon either. So in general, about 37 to 40% of men are circumcised, and most of them are performed due to various reasons, but only 30% are done due to medical reasons. So these are the what I call the life. We're starting with as a baby, young, adult, seniors, and this is also the way of how we do circumcision in different stages. Patient may come to you during baby or neonatal periods, or when they are young, we usually perform, and so as around 40% of them will come in during adult or senior periods. So today I will be talking about adult and senior citizens who are going for adult circumcision. So there will be a lot of evidence saying that how early the neonatal circumcision was performed, backdated in what I call in 1,300 centuries, and then this is evidence in the one of the museum in Israel. And then this is more definitive evidence shows in 1871, around that in Central Asia, Turkmenistan, showing a clearly photograph evidence of early neonatal circumcision or during childhood circumcision. However, do we aware that actually adult circumcision was started many years ago, 1,000 years ago, during ancient Egypt, what I call about 2,300 before centuries. So this is the evidence of adult circumcision in Saqqara, Egypt. And there is another evidence of what I call adult circumcision performed back earlier than the neonatal circumcisions. So actually adult circumcision was actually performed earlier compared to neonatal circumcisions. So basically what are the indications for adult circumcisions? We can classify into three. Either they come for penile pathology, or they come for the preventions, which was established, and then or they come for aesthetic or what I call this sexual functions. So under the penile pathology, they may come to you. The most common one with phimosis is the most common what I call etiology or cause why adults come to you. They may come to you with paraphimosis, balanitis, all form of infection, genital coniloma or warts, UTI, prostatitis, or any other form of penile problem in the pubis or in the glands. In terms of preventions, it's well established by WHO that it prevents patients from STDs, HIV, and penile CA. But penile CA basically when you perform during the early adolescence, not during the neonatal. And not to forget about aesthetic, some people come to you because they believe they may have some better appearance of the penis. But this evidence, not evidence, it is a survey by the one of the journals that 90% of women say that circumcised penis looks better, and 92% looks thinner, and 85% more pleasant to touch. So basically, they're giving A to all the men with circumcised penis. So having said that, most circumcisions are done in what I call a clinic-based procedure, but however, bear in mind that you have to know which are patients that clinic setting may not be so what I call appropriate. So the absolute contraindications for not to do circumcision in the clinic-based setting will be anatomical anatomy of the penis, such as hypospadias, epispadias, chronic paraphimosis, when the glands will be taken, genital ulcer disease, which may turn out to be penile ulcer, urethral discharge, which correlate with STDs, or other obvious pathology such as penile CA or any other blood disorders such as hemophilia. So in terms of relative, you can do in clinic, if tight pharmacy, you're able to do under proper LA, or scar tissue and frenulum because of chronic scars, penile warts, and last but not least is BXO, which commonly occur in elderly patients. So what are the positive effects of doing adult circumcision? Basically, they will have evidence of improved hygiene, they will reduce the rate of sexual transmitted disease, and then the most common, the most established evidence is the reductions of HIV in many of the African countries. So in 2007, WHO have endorsed that circumcision is the most additional weapon in fight against AIDS. And even they set up to the level of that circumcision is equal as giving vaccines to the patients. So however, there are some cons during circumcisions, where some of the patients, they said they may have what I call this evidence or experience a decrease in erectile functions and sensitivity. They also complain of their sex life is frozen, and they decrease pressure in masturbations. And the last one, they said increase in their ejaculatory latency, meaning a delay in ejaculations. But I think probably a plus point sometime, no, for having a delay ejaculations. So basically, how to remove a full-grown foreskins in adult? Basically, in pediatric, maybe slightly easy, but I think just that they may come to you with congenital abnormalities. But in full-grown adult, there are a few methods how doing this. So actually, we go back to this 2,300 centuries before, where these pictures already describe how for us to do a adult circumcision. So these are the adult patients. So actually, they're able to translate the manuscript. So what the manuscript said, basically the first, let me see, they put that the guy there is there is a ceremony of circumcision. There's a priest there, and then so the second sign so that hold him properly, don't let him fall over, and then the third shows that manuscript shows that as well as your desire, and then cut indeed thoroughly, and I will proceed comfortably. So these are well established ways of doing adult circumcision. So probably I can end up ending my talk here because you can follow this way of doing circumcision. So, okay, I think most of us do receive this WhatsApp before, I think last year or the second year, but I couldn't play the. So this is how a child doing a circumcision. So I think not the adult. So well, this I meaning this boy, not how I do it. So there are numerous techniques of doing adult circumcisions, and as a practitioner or surgeons, we should choose the technique that we are most comfortable to perform. So this is the example of armies in Philippines performing circumcision in an adult patients in one of the village. So basically, this don't follow the how I do in the boy. So basically, the principle is asepsis, adequate excisions are outtake in the skin, hemostasis, and then the most important is protecting the glands and the urethra, and last but not least is cosmesis. So when you do a circumcision, it's basically is to satisfy yourself rather than satisfy the patient. So you might have a very good cosmetic results. So at the end of the day, the goal of the procedure is basically to expose the glands sufficiently and to prevent the presence of phimosis or paraphimosis. So the key principle, basically, you must have a basic surgical skill. The practitioner or the performance surgeon should have some preparations of the equipments, and then don't rush doing surgery, especially when doing mass circumcisions. But most of the time, adult, they don't come as a mass circumcision, they will come to you as walk-in patients in a clinic. And then proper sterile techniques, I mentioned earlier. And then they should know the limitation in terms of their expertise. They shouldn't treat or do patients with congenital abnormalities. They also, adult hypospadias come to you once in a while, so this needs to be referred to the tertiary center. And then it will be very good if you have a very good trained assistant. And last but not least, to follow the WHO Safe Surgery, Safe Life to improve the safety safety features. So basically, these are the basic procedure how to do this. I won't go through. I think basically we prep, drape, give LA, choose our technique, and then prevent any complications. And then, as I mentioned here, one of the most important is to know the anatomy of the frenulum, because frenulum is for men is like clitoris, so you must avoid injury to that. You must avoid the you must secure the bleeding well there. And then most of the patients that come to us with complications, one of them is bleeding and injury to the frenulum. When they use excessive bleed, or when they cut too close, or when they have distorted anatomy of the frenulum and the meatus. So basically, these are the points that I would like to highlight in doing adult circumcision. Basically, how to handle the tissue, how to do the skin prep, how to give local, because most of them come to you with as a walk-in patient to do local anesthesia, and suturing, which are the good, best sutures to use, and last but not least, the dressings of the wound. So tissue handling, as usual, we have to handle with care, and then don't use any arteries. Use a proper forceps. Then we either use Adson's forceps or fine Gillis forceps. And then, as again, avoid inserting when you do suturing technique for hemostasis. Don't go too deep, which can cause injury to the corpora. So basically, if you probably don't notice that there are few sutures when you do a proper circumcision. Basically, there are three types of sutures when you do a proper circumcision. There will be simple interrupted, vertical mattress, and horizontal mattress. So the most important here is the frenulum, where we suggest to do a horizontal mattress suture. So this will secure the blood, fenular artery very good. So if you look at the diagram again, so basically just put in the clockwise positions, 12, 3, 6, and 9. So basically the sutures, you do the most important is horizontal mattress and the frenulum at 6 o'clock. And then you put the this vertical mattress at 3 and 9, and then simple in between the between the mattress sutures. So this is the proper way of doing adult circumcisions, and this may apply to the neonatal or childhood circumcision as well. So which are the best sutures to use? They recommend to use 3 or 4O as a verbal suture, such as chromic, bicrel, or monocrel. I think chromic probably not much of people use it anymore, and bicrel, maybe bicrel rapid or normal bicrel also can. So in adult, I prefer to use 3O, but if the penis is quite small, you can use 4O. And then, and for children, you just bring down one size of the sutures, like 4O and 5O suture in neonatal or in pediatric patients. And then you can use tapered cutting, round body, or reverse cutting, up to your preference. So the skin prep also important. You must start in the middle, go to periphery. This is the basics of doing skin prep. And then you must retract the foreskin in order to clean the glands. And then the area should in the penis, scrotum, adjacent area, the thigh, and pubic regions. And you can use either povidone iodine or chlorhexidine. So it depends on your preference. I sometimes use both. Depends on what they have normally. But the advantage is povidone iodine can stain the skins and can cause irritation post-op. So this is also another important issue. Anesthesia normally we do adult skin under LA. So we only use plain lidocaine of about 3 mg per kg per body weight. If you use epinephrine, you can add up to 7 mg per kg. But when you do circumcision, the most important is to avoid using epinephrine because it can cause ischemia. Okay. So we have few cases, even a surgeon also, because the staff nurse, they used to mix with the epinephrine. So it happened once in a while, so just be careful. And then you can use 1% or 2%, depending on the strength you have. And then in adult, basically 40 or 70 kilo, we can use maximums of 12 or 21 in 1% lidocaine. This is very important because this can cause a lot of problem if you have overdose such as arrhythmias. It happened before, but it happened in the pediatric patients. So that is not clinic circumcision, not hospital circumcision, it's house circumcision done by the father. Father is the medical staff to bring to the hospital because the son having arrhythmias. So just be careful, make sure you know the dose. I think to be safe, just use maximum 10 of 1% and probably 5, I think should be okay. So in doing LA, the two techniques, a ring block or the nerve block. So the ring block basically you give at the 12 o'clock and you can use 2 or 3 incisions of needle and small needle 23 to 27 gauge. And then you put 2-3 mm into the skin. Make sure it's covered the dorsal nerve. So when you do at 6 o'clock near the urethra, you must be careful. Normally I put 2 incisions at the 12 and 6. So far no issue. But when you do at the ventral part near the urethra, you should be careful. If you worry, you just can put at 12 o'clock and then 3 and 9 and cover the ventral part. So the dorsal nerve blocks, there are 2 nerve running. At 1 o'clock and 11 o'clock, there's a place when to put your needle. You should be able to feel the give of the there. So you must be perpendicular to the syphilis, and then you go deeper about 2 to 3 centimeters inside. So this can be single or combined with your ring block. So normally I prefer to use the ring block because it always works. But this one sometimes it's not working because sometimes the incisions of the needle is not so deep. So these are the technique, the well-established technique recommended by WHO. You can use forceps guided or gelatin technique, dorsal slit or excision, the sleeve technique, and last but not least the shield or clamp technique. So I think the guillotine technique or forceps guided technique is fast and quick to learn. This is how we do what we call that. The most important is the glans penis should be protected, and then people sometimes put the clamp either you put horizontally or vertically, and then the most important before cutting the foreskin, you must really make sure that the glans is below your artery. So you can cut either using a scalpel blade or using a bipolar. I think Mr. Tamiz is using bipolar when I was with him in Kota Baru. But I don't use this technique because I always feel that my glans is going to be cut. So better to use if you're very confident only. So again, the statement, if you're in doubt, don't cut. So always check and recheck before you cut the prepuce. So then when you cut, again, you get you control the hemostasis, and then get the frenulum artery, frenulum vessels, and then do the suturing as mentioned earlier. And then normally you can stabilize at 12 and 6 o'clock, and then do the mitral suture here, and complete your simple suture throughout the wound or the penis. So dorsal slit, okay, this is still a gold standard. It's the most common, especially when you have a tight prepuce such as phimosis. And then the best is you can visualize the glands, so it's very safe. But it takes some time because you don't need to do a lot of cuttings, and you need to use a lot of arteries. But when you put the artery forceps, be careful, don't injure the meatus, because you need to do the under direct visions. So this is the step. Get two arteries at 1 o'clock and 11 o'clock. Get the foreskins, and then use the artery forceps at 12 o'clock, about 10 to 15 seconds, just to hemostasis the prepuce and the foreskins. And then when you cut circumferentially under direct visions. So as you see, if you notice, our glans penis is not straight, it's diverted up. So you need this V-shape, what I call V-shape. You have to follow the V-shape of the frenulum when you go towards the frenulum. So don't cut as a round shape, cutting lah. So because you should follow the frenulum. So because our glans or the corona is not straight, it's towards the frenulum. So it should be in the V shape when you go to towards the frenulum. Otherwise, you're going to have a deficiency of skins in the ventral near the frenulum region. So you can see it is under direct visions. So and then you follow the same step as the what I call the gelatin technique. So another technique is sleeve techniques. This technique has very nice appearance, but it takes some time to learn or to do, and then it's almost bloodless because you cut the skin datos with the clear margin, upper and lower margin, and then gland also well visualized. So you mark the outer part just below the corona, and then when you retract the penis, you mark again 5 mm below the corona, and then you cut based on the marker earlier, and then you just remove the sleeve. So you're gonna have a very nice sleeve and cutting with the good edge of our penis. So last but not least, shield and clamp also come under these WHO recommendations. The advantage is quick, easy, less care provider, and then less bleeding because it's well compressed, the vessel around the prepuce, and no stitches required. And then sometimes you only need topical anesthetic and no need to have injections. The advantage is they have to wear about 1 week or 10 days, and then they require second visit most of the time. They may have pain initial because of the clamp, and then necrosis of the foreskin take 1 week to occur, and then you need the clinic. You have to refer back to the clinic if anything happens. So there's so many clamps in the market. So the problem with the clamp is to fit the adult size. No problem with the childhood, but the adult have problems. So not all the clamps and shield are available. So this sample of Gomco clamp. I never seen this before, but this is a recommendation by the WHO. I just mentioned it. So this Morgan clamp and Plastibel. I think we have heard about Plastibel before. And then rings, we have Zenzi's ring, we have Smart clamp, and they have Tara clamp from Malaysia, Smart clamp from Malaysia. And then they have adult size, but not many. These are the adult size, not for kids. So and Sheng ring is very good. I will explain later. Then this is how Morgan's clamp. It's like gelatin technique. So you need to flush, make sure again the glass is not in the way. And then when you exercise, it's a very clean incisions because you really crush the what I call the prepuce. So plastic belt basically again just put into the corona and tie and let the skin necrose. And then the problem is we don't have many adult size, so it's easy to dislodge because men have erections. So this is a problem with plastic belt. But if the man, the adult, have a smaller penis, we can use this one also. So another one is Gonko clamp. Gonko clamp it look complicated, but it's not really. But it's one of the device used for patient in HIV endemic countries and recommended also by WHO. So basically, you have to do dorsal slit, put in the bell inside, and put the instrument in, and then make sure the skin in the gland is not inside too. Take the skin up, and then you're very sure, and then you cut. So more or less like a guillotine technique as well. So this I have to mention also because this is one of the device used by WHO to reduce the risk of HIV. And then the best part, they said there's no injections, no surgery, no suture, no sterile. So basically patient come, put and go back. Don't need a very thorough preparation. Basically you have to measure, they have adult size, and then mark the corona, and then put the ring, inner ring, and then get the what I call the ring in place, and then tie at the base of the penis, and then you have to put the inner ring inside, and then clamp it, and then the patient will. I don't have the video, but I've seen the video before. So it's really gangrene, so this become black. So when you cut, it's like cutting on the thick paper. So when you remove all these things, and then you can remove the ring, and then so you can have a nice a wound post what I call removal of the ring. So Sheng ring, okay, have been used quite regular in the African country. It's well established. It's recommended by WHO. And then this is the first generation, I think. So they also came to Malaysia 2-3 years ago, and it's very useful. You only use local ancestor EMBLA to apply, and then and locking mechanism. They have two ways of doing this. This is the first version where you have to put and invert the inner skin. So sometimes difficulty in inverting the skin and put the external ring. So once you put, you can access a bit or trim a bit the skin, and then so make sure all you cover everything except for and be careful of the meatus and frenulum. So patient will come to you after 7 days, and then the new patient come in. You don't need to invert the skin. You just come, plug in, and then wait for 7 to 10 days. So we have some of urologists went to China also to visit the center. It's quite good. They try to improve their products. At least got 2 generations of Sheng ring, and then in even the WHO also recognize their device, and then mainly for adult patient in HIV endemic countries. So the problem is the cost is slightly expensive in terms of the device itself, not the total procedure device itself. So I think in conclusions, it's indicated, male adult circumcision indicated in for cultural, religious, for most of benign pathologies, and it's already proven to reduce STDs, HIV in endemic countries. And most important is I have mentioned to you the multiple techniques, but you must be able to understand the anatomy well and choose your preference technique. So so that you do it in nicely without causing any complications to the patients. With that, I end up my.
Okay, thank you very much, Dr. Saiful Azli bin Muhammad Zainuddin. Now we are pleased to open the floor for the Q&A sessions. We also open for the international participant from the webinar part. Please, if you have any questions, you can ask by using the microphone provided.
Hello. Oh yeah, I got it. Thank you. Yeah, thank you very much for the introduction on the various techniques of doing circumcision. My question is, what is the best technique for adult circumcision? Thank you.
So the best technique, I only choose one technique for the past maybe 20 years since I know how to do circumcisions, and this will be a dorsal slit technique. So to me, it's very safe. You can have, you reduce a lot of complications, and even though they mention it takes sometimes to perform, but for preference, you have to think two things: preference or cosmesis. In terms of cosmesis, sleeve technique is the best, but it takes some learning curve to do. I think if you choose both dorsal slit or sleeve or dorsal slit or sleeve technique, sleeve is better in terms of cosmesis. But to be safe and to do in a appropriate time, dorsal slit is still a very good or just a gold standard technique. So I suggest to choose either these two techniques.
I have one question regarding the dorsal slit technique. What is your preference, whether to cut with cold instrument, scissors, or you can use powered instrument, or not powered instrument, I mean diatomy or bipolar, but still following the dorsal slit principle.
Okay. So it's a very good technique, a very good question, because we have seen this what I call trend of people using diatomy, or people claim to use lasers in terms of doing circumcisions. It's not limited to the pediatric people, also limited. It's go up to the adult population as well. So in my opinion, it's still the best to use scissors. The reason being because you can have very nice clean wound or edge, and then the problem with the what so-called diatomy or what I call these lasers, first of all, we are not sure what kind of diatomy they use. The one that I've seen, I've joined some circumcisions, is the one they use, the one with the very reddish wire. So the problem, we don't know how much the power being transmitted to the glans penis. So this is the risk of injury to the glans, and most of all is to the frenulum.
My experience with this energy powered instrument is edema because of the heat. So it makes technically easy for us to doing the circumcision.
Yeah.
But when we send the patient home, it's actually the edema. Yeah. I think the edema is much worse compared to the cold instrument.
Yeah. So they may come to with perpetual cyst, edema, and injury to the frenulum or meatus.
Dr. Saiful Azli, I just have one question about sleeve resection technique. You do reset, is starting from the base of the penis, or is near to the mucosa ataupun near to the prepuce? Which one you choose for the resection technique?
There are two incisions you need to make.
Yeah.
First is outer skin, where you mark near or just close to the corona. So when you retract your foreskins, if you probably didn't notice, I didn't show here, you can retract when you have erected penis, your prepuce can go down up to the base of the penis. So the first incision is at the corona, and the second incision is inner. So the inner one is to take about 5 mm from the corona itself. So when you mark these two, you're gonna have two sleeve of skins. But to be frankly speaking, I don't do this technique because it's time consuming, and I believe you don't need to do a very cosmesis circumcision. It's just that more towards your satisfaction. You have very good I don't know, I mean, as urologists know, We don't need to have very beauty penis. We have to have a good penis. That's all.
Okay, is there any questions from participants? Feel free to ask. Okay, I think that's all for today. Thank you very much, Dr. Saiful Azli bin Muhammad Zainuddin.